I want you to picture a scene. It plays out every single night. In hospitals all over the world, it's 3.0.
Right.
You're in the basement, in the radiology reading room. It's pitch black, except for the glow of these massive high-resolution monitors.
Displaying, slices of a human brain or chest cavity.
And sitting there is a radiologist, probably exhausted, maybe on their fourth coffee speaking at 1,000,000 miles an hour into a handheld microphone.
It's high-speed dictation.
Yeah.
They're literally talking the patient's medical record into existence.
Yeah.
And because of that volume and that pressure, they rely entirely on speech recognition software. They talk, the algorithm types.
And, usually that works. But today we are looking at the cracks in that system. We're doing a deep dive into a study published in Radiology, artificial intelligence that asks a pretty terrifying question.
Wow.
What happens when the software blinks? What happens when it hears no hemorrhage but types now hemorrhage?
It's the difference between sending a patient home and rushing them into the operating room.
Exactly.
The paper is titled Generative Large Language Models for Detection of Speech Recognition Errors in Radiology Reports. It's a bit of a mouthful, but the implications are huge.
So essentially, we're looking at whether this new wave of AI, LLMs like GPT-4 can act as a safety net.
A safety net for the older, dumber AI that's currently transcribing these doctors' voices.
That's the mission, then.
That's the mission. The researchers, led by Dr. Ruben Schmidt and his team, wanted to see if these models could proofread radiology reports better than humans and, better than previous software.
Yeah.
Because the error rate in raw dictation is, well, it's shockingly high.
I was looking at that background data they cited. Speech recognition errors in 20 to 60% of dictated reports. That seems incredibly volatile for a medical setting.
It does sound high, I know, but you have to filter that number. The vast majority of those are harmless, a missing comma, a capitalization error, that sort of thing. But the study zooms in on the dangerous ones. They estimate about 2% of reports contain clinically significant errors.
Which doesn't sound like a lot until you realize a busy hospital might process thousands of scans a week.
Exactly.
2% adds up fast. That's dozens of patients potentially getting the wrong care.
Yeah, precisely.
Yeah.
And the types of errors aren't just typos. They're fundamental shifts in reality.
Let's get into that, because the taxonomy of errors in the study was, it was fascinating. It's not just spelling.
No, the researchers broke it down into these categories to really, stress test the AI.
Yeah.
You have your standard nonsense phrases.
Which are usually easy to spot.
Usually.
The famous example from the study being the lungs nuclear.
Right. The radiologist said the lungs are clear. The software, maybe confused by a mumble or some background noise, transcribed the lungs nuclear.
Which, unless we're treating Godzilla, is probably not a valid medical finding.
Exactly. A human or a smart AI should catch that because it violates what they call radiologic fluency. It just doesn't sound like a doctor.
Okay.
But then you have the darker category, omissions.
These kept me up at night reading this. This is where a word just vanishes.
It is usually a critical one. The dataset included an example where the text read, intracranial hemorrhage.
But the audio said.
The audio clearly said, no intracranial hemorrhage.
Wow. That is a catastrophic failure. And a normal spell check isn't going to catch that, because intracranial hemorrhage is a perfectly valid phrase.
It's just factually the opposite of the truth.
Right.
So the proofreader needs to understand context. Then you have homonyms.
The classic right versus right.
Or the lung versus the lung. Again, legacy software struggles here. It's just matching sounds phones to words without any real understanding.
But the category I found most interesting, and where I think the smart AI really has to shine, is the internal inconsistency.
Yes. This is the holy grail of automated proofreading.
It requires logic to catch.
Right. An internal inconsistency is when the report contradicts itself. The example they tracked was a kidney stone, a calculus.
So early in the report, the radiologist describes a stone in the left ureter.
They give the size, the location, everything.
But then down in the summary, they refer to it as a right ureteric calculus.
The stone magically teleported across the body. Now, if you look at those sentences in isolation, they're both perfect. Left ureteric calculus is valid. Right ureteric calculus is valid.
The error only exists when you compare them.
Exactly. Which means a proofreader looking sentence by sentence, which is how most older tech works.
It's going to miss it every single time.
Every time. You need a context window that's large enough to hold the whole report in its memory.
And there's one more category I hadn't even thought of. Template errors.
Ah, the copy-paste problem.
So radiologists use these templates to speed things up, insert normal chest exam, that kind of thing.
Yes, they pull in a whole block of text that says, lungs are clear, heart is normal size, etc.
Yeah.
But sometimes they pull in that normal template and then they dictate a specific finding that contradicts it.
So you get a report that says lungs are clear in the template.
But the next sentence says, large mass noted in right lower lobe.
Yeah.
He creates a schizophrenic report.
And again, no words are misspelled. It's a logic error.
Precisely.
So we have this minefield. Nonsense, omissions, teleporting kidney stones, and now template clashes. The researchers wanted to see if generative AI could clean this up.
Better than we can, anyway.
So let's talk about the setup. They didn't just ask ChatGPT to fix it, right?
Oh, no. This is where the study gets really technical in a cool way. They used 3,233 de-identified reports to create their data set. But the way they talk to the AI is a masterclass in prompt engineering.
I was reading about that. They adapted this ADA-test method. They iterated on the instructions over 100 times.
They treated the prompt like software code. They tweaked it, they tested it, refined it. They used something called chain of thought prompting.
Which is basically asking the AI to show its work.
Exactly. Instead of just asking, is there an error, they tell the model to reason through the text step by step before giving a final answer. It forces the model to slow down, so to speak.
And that reduces hallucinations.
It does, and they use few-shot learning.
So you give it examples.
Right. Here is a bad report. Here is the corrected version. Now do this for the new text. It anchors the model's expectations.
And they messed with the temperature, which isn't about heat.
No, it's the chaos style.
Yeah.
A high temperature means high creativity, high randomness. A temperature of 0 is deterministic. It gives the same answer every time.
And in medicine, you want a temperature of 0.
You do not want the AI getting creative with a cancer diagnosis. No.
So they have these tuned-up prompts. They enter the arena with 5 contenders. GPT-4, the older GPT 3.5, TextDaVinci 0003, Meta's Llama 2, and Google's Bard.
The battle of the titans.
And looking at the results, it wasn't really a fair fight.
No, GPT-4 wiped the floor with them. It was dominant. For clinically significant errors, the ones that hurt patients GPT-4 achieved a recall of 100% in the test set.
Okay, I have to stop you there. 100%. As someone who reads a lot of data, whenever I see 100%, my skepticism alarm goes off. Nothing works 100% of the time.
And you are right to be skeptical, and the authors note this too. 100% applies to this specific test set of known significant errors. It doesn't mean the model is perfect in the wild forever.
Okay, that's an important caveat.
But even with that caveat, it caught every single dangerous error they threw at it in that final validation phase.
That is still wildly impressive. What was the F1 score?
The F1 score, which balances finding errors against, not flagging false positives, was 86.9% for GPT-4.
And to frame that, how did the others do?
The next best was an older OpenAI model at 72%. Llama was around 72.8%. But look at Bard.
Google's Bard.
It crashed and burned. For significant errors, its F1 score was around 38.5%.
That is a massive discrepancy. You have one model basically acing the exam and another failing, 2 out of 3 times? Why?
It comes down to that context window and reasoning capability we touched on.
Okay.
Remember the internal inconsistencies, the 12 errors where the report contradicted itself.
The teleporting kidney stones.
GPT-4 caught 12 out of 12,
100%.
100%. It successfully held the entire narrative in its head. Bard caught 33% of them.
Wow.
It just couldn't connect the dots between paragraph 1 and paragraph 4.
So Bard is just reading sentences while GPT-4 is reading the whole story.
Essentially, yes. GPT-4 demonstrates a much higher radiologic fluency. It understands not just the words, but the logic of the exam.
So GPT-4 is the clear winner. But I want to pivot back to something we glossed over. To test these bots, they needed a ground truth.
Right. They needed to know where the errors actually were.
So they had humans, residents, and attending radiologists manually review these thousands of reports, and that process gave us some really uncomfortable data about who's making these errors in the first place.
This is the human element section of the study, and honestly, it's just as important as the AI part.
It turns out not all radiologists are created equal when it comes to dictation.
No. The first stat that jumped out was experience. Residents, the trainees, were more than twice as likely to make errors compared to the attending physicians.
That makes sense, I guess. They're learning, they're stressed.
It's to be expected. But then there's the fatigue factor, the overnight shift.
This is the critical finding. Reports dictated during the overnight shift, we're talking that 3.00 a.m. window, had significantly higher error rates. The odds ratio was 1.9.
So you are nearly twice as likely to have a typo in your medical record if you come in at night versus during the day.
That's sobering.
Physiological fatigue is real. But here's the kicker. In a teaching hospital, residents dictate the reports, but an attending the boss signs off on them.
Right, so there is already a human safety net. The boss is supposed to catch the resident's mistake.
So why do the errors slip through? The study discusses inattentional blindness and confirmation bias.
It's the autocorrect in your brain phenomenon.
That's a perfect way to put it. The attending looks at the scans, sees normal lungs. They look at the report, skim the text. Their brain expects to see normal lungs. So when the text says lungs nuclear, their brain just fills in the gap.
They see what should be there, not what is there.
They're anchored to the image. And this is why AI is such a powerful tool here. The AI doesn't have confirmation bias. It doesn't look at the image. It only looks at the text.
It's the ultimate unbiased observer. It's not tired. It's not anchoring. It's just processing syntax and logic.
It breaks that chain of human assumption.
So, if the solution is this obvious GPT-4 catches everything, humans are tired and biased, why isn't this running in every hospital right now?
Because of the elephant in the room. Privacy.
We're talking about highly sensitive patient data.
To use GPT-4, at least as of this study, you have to send your data to OpenAI servers. It leaves the hospital firewall.
Which is a non-starter for most institutions.
Exactly. You can't just upload Mrs. Smith's brain tumor analysis to the cloud.
So that brings us to the alternative they tested, Llama, the open source model.
Theoretically, this is the solution. You download Llama, you put it on a secure server in the hospital basement. No data ever leaves the building.
But we saw the scores.
Right. Llama scored 72.8% on significant errors compared to GPT-4's 86.9%. And on other errors, the gap was even wider.
So that's the dilemma. You can have total privacy and mediocre performance, or you can have high performance and risk data privacy.
It's a classic trade-off.
Yeah.
The authors basically conclude that for now, open source models aren't quite ready out of the box. They need significant fine-tuning, specialized training to catch up.
And is 72% good enough? I mean, it's better than nothing.
It is, but remember, if an AI flags too many false positives, doctors get annoyed.
Yeah.
It's called alert fatigue. If it misses too many real errors, it's just false security. You really need that high F1 score to make it a viable tool.
And just to clarify, the vision here isn't that the AI quietly fixes the report in the background?
Absolutely not. No, that would be dangerous. The concept is decision support.
For the bouncing paperclip approach.
It
Looks like you're trying to diagnose a stroke.
Hopefully less annoying than Clippy. But yes, it highlights the potential error. It marks the lungs nuclear in red and suggests that the lungs are clear. The human doctor has to click accept.
The human stays in the loop.
The human is the pilot. The AI is the collision warning system.
We're running out of time, but I want to leave listeners with a final thought from the author's discussion. It's about the risk of these models getting too good.
This is the hallucination problem, but a really specific version of it.
Right. We talked about nonsense errors, phrases that mean nothing. They're easy to spot because they look broken. Lungs nuclears, obviously wrong.
Obviously.
But as these LLMs get more fluent, they stop writing nonsense. They write perfect, beautiful medical English.
And that's the danger. Imagine the resident mumbles something ambiguous. The AI hallucinates a correction. It writes a sentence that is grammatically perfect and medically plausible. There's a 5-millimeter nodule in the upper lobe.
But what if that nodule isn't actually there?
Then you have a smooth lie. And because of that confirmation bias we talked about, that tired doctor at 3 a.m., they're much more likely to accept a sentence that reads well than a sentence that looks broken.
So we might be trading obvious typos for invisible lies.
It's a real risk. If the AI sounds too confident, the human stops checking. You can't let the fresh set of eyes become the blind leading the blind.
It brings us right back to the core lesson. AI is a tool, not a replacement for critical thinking. Next time you read a medical report, just remember there's a battle happening behind the scenes between fatigue, technology, and the humble typo. Thanks for joining us on this deep dive.
Thank you. Always a pleasure.